Good afternoon, Jason. Thank you so much for joining me for a Corona conversation. Perhaps if you could just start by telling people who you are, what you do for a job, and where you are at the moment in the world.
Thank you. Hi, Adam, and thanks for having me, by the way. It's a real privilege to speak with you personally, but also for the Global Drug Survey as well. So, which is an organisation which I've followed for quite some time, and it really helps me in my professional capacity and also my ability to learn. So thank you very much for that. So I'm Jason Kew. I'm a Detective Chief Inspector with the South East Regional Crime Unit, and I work also for Thames Valley Police. So it's important that I begin with a position that I can speak personally about policy and my own views, but they don't necessarily represent that of my organisation, and that's really crucial to start with, really. So, but I'm very happy to speak freely. So, who am I? So I'm a 26-year detective. I've worked on a variety of teams, from enforcement to murder, kidnap, acquisitive crime, and also more recently policy. But throughout all of those years, I've seen and been impacted professionally by the increases in drug-related deaths, which every single one of those is someone's son, daughter, father, brother, homeless person who you might walk past on the street, but they can so easily become statistical. And I think it's really important to humanize those numbers. The statistics are very easy to read on a blank bit of paper, and they fill an evidence base, but actually there's a human element to that too. And I very passionately speak for those most marginalized and vulnerable within our communities in order to provide a voice for them. Because if I don't, and I'm not some messiah by any means, I work with some remarkable people within the cross-sector charity and drug policy groups, from transform drug policy to release to collective voice, but also policymakers and enforcers too, to shape policy. I think it's really important to get a breadth of voices involved, but none more so than those with lived experience. And I think that's absolutely crucial to informing policy. So as an example, I've developed drug diversion within Thames Valley Police, which no longer, for those found in possession of police, requires an arrest, interview, nor an admission of guilt. And that diverts someone for a drugs education and an assessment about their use. And that's already seeing significantly positive results for young people, particularly because it doesn't leave a criminal footprint to ruin the rest of their lives. But also it enables education for the first time in many people's lives about what the substance is. And I know we've spoken previously about that and how we can collaborate further. But for adults too, there's a real need to reduce the stigma about what drug use is about. It's clear that the majority of drug use is non-problematic. But then when someone might be on the verge of approaching problematic drug use, well, how do they know that? How do they know that that's the tipping point into addiction? And I think stigma can have a hugely damaging effect on people from accessing help or support when approaching that position. And I think we really do need to understand addiction a lot better within society. And I think coming from a serving police officer, my voice presents a different edge to that conversation. I think I can create permission within certain sectors of policing and enforcement to say, look, it's actually okay to talk about decriminalisation. There's strong evidence in Portugal to decriminalise, and we need to look at that evidence base, not be frightened of it.
I'm sure people watching this, Jason, will probably be lifting their chin off the table and finding what you say unbelievably refreshing, but also rather disorientating to have someone who's a serving police officer with such a pragmatic humanitarian view. I'm just wondering what your colleagues think of your perspective. Do they see you as some random outlier, or do they recognize you offer an important balance to kind of the prevailing view?
That's a brilliant question. I think some might, to answer that bluntly. I think some may well think I'm a bit too radical for policing, but actually all I do is present an evidence-based opinion or present an evidence-based argument to counter. I'll give you an example. So heroin-assisted treatment is, in the eyes of some aspects of the media, completely left field. It's completely radical. How can you give, and this is a headline, how can you give free heroin to addicts? But how damaging is that headline? Do you think, actually, when you break that down, that's prescribed diamorphine, the same substance as a pregnant woman or a woman in childbirth is given in hospital. It's the same substance. But when it comes to problematic heroin use, that substance, it's no longer a drug of choice. It's a drug of need. People need to understand what the reasons for that problematic use is. But when you present that argument then to policing circles to counter that different edge to people may well think I'm radical in thinking this, but actually when you break it down and look at the UK riot trial evidence base, that it's evidence that the top 10% heaviest using group for heroin consume 50 to 66% of all illicit heroin. If you prescribe diamorphine to that top 10%, you could eliminate 50 to 66% of the organised crime in that area. And so the total amount that policing sees nationally in the UK is about 2 to 3%, I believe, of all the imported drugs. Well, if by taking a medical intervention, you can eliminate that sizable chunk of the market, then clearly a health-based approach works. It's a no-brainer. But it goes further, because the acquisitive disruption to that top 10%. So they, within 6 months, surveyed. The cohort on the riot trial was surveyed after 6 months, and the acquisitive crime dropped by 78%. And that's significant. You couldn't achieve that same disruption by policing.
You're offering a medical solution to a policing and social problem. You've removed morality from the discussion, and that's, I think what you've done so brilliantly. And it's allowing people to say there are multiple solutions to very complex problems, and they may not be the solutions we've relied on without that much success for the last 4 or 5 decades. I think the world is changing. Yeah, so you just mentioned something that we perhaps, sees 5 to 6% of illicit drugs coming into the UK. So my next question is specifically around, from your perspective or from what you're aware, what's been the impact so far on UK drug markets of COVID? On drugs coming in, seizures. Do you have any information about that?
So what I can summarise really is that, and this will be completely obvious, there's been some really good reporting actually from Max Daly from Vice, and also Ian Hamilton as well. Some really good informative articles. Steve Rolls contributed to one too, and I think they paint a real honest picture about supply will be clogged in a system because of the travel restrictions, and it's clear that air freight has drastically reduced. Road freight is a lot more exposed, so commodities arriving into the UK will be vastly reduced. So really, it will be a survival, in organised crime terms, survival of the fittest. So who's got stocks, who's got the commodity availability, and I think those that have will maintain their presence and adapt their supply accordingly. So therefore, the train routes are difficult for, and I don't like this phrase county lines because it's always been around, but child exploitation will have to change, or the supply methods of county lines will have to change to adapt to the more exposed environment. So therefore, county lines may well rely on vehicles, for instance, to get the commodities to the areas that they're supplying from. And in-house supply may well last a lot longer than traditionally before. So I think the market is rapidly changing. There are severe risks though. If heroin, and this is a personal opinion, I have no academic evidence base to support this really, but it's clear that if heroin starts to have a severe impact on shortage on users, well, that, going back to the top 10% heaviest user group, if they consume so much illicit heroin, then there are risks that their resilience, personal resilience to using for high potency, high purity drugs will decrease, and therefore, if that then might open the door to a gateway for more synthetics to come over the dark web or fast parcels, then that creates a significant risk to a great number of people. And I think it's that shock to the supply mechanism. So if users are caught out, then we could see an increase in fatalities. Now, we already have the highest number of drug-related deaths on record. We don't need any extra risks, and we've got enough problems as they are. So we really need to rapidly adapt and to rapidly work with those people who are in the most marginalised groups.
And the government certainly responded in terms of, making it easier for people to come into treatment, providing more unsupervised doses, and something from the ACMD today suggests that pharmacies will be able to continue scripts, based on their own judgment without a prescription. So treatment services are ramping up. Do you have any idea whether there's been greater disruption to the cocaine market or heroin market in the UK? I mean, I understand that prices of bulk coke have gone up from maybe 35,000 a kilo to 50,000 a kilo. Is there disruption to the heroin market in the same way?
Yeah, I've heard. So echo what you just said there about the cocaine market. I think there is some profiteering going on. It's exactly the same marketing tactic as the loo rolls that we saw, really, I think. But the heroin market is changing. I think deals are off, so there's no new suppliers coming in. So it's just that concentrated that concentrated kind of availability through trusted suppliers, if that makes sense. But there's certainly no deals on the table. But we're not seeing, as far as I can tell, a huge disruption in heroin just yet. But as the longer this lockdown goes on, clearly supply isn't coming in.
This is a question I've asked several people. No one has the answer. Do you have any idea how many weeks or months reserves of Class A drugs the UK has?
No, I need a mathematician. So if you can hypothesize, so we have 320,000 registered people with a heroin addiction. So nationally, if we are seizing around about 5%, then, and I'm not good at maths, I'm going to show myself up big time here, but that's a significant quantity out there that's not within the public domain, if that makes sense. So I imagine there is a stockpile. I wouldn't know how long that would last. Okay. I think there are indicators that we might well see on the dark web, for instance, chatter, for instance, people chasing up supply routes, for instance, or competition. And I think the first thing the policing will see is that competition. So an increase in violence, so more drug dealer on drug dealer robberies, kidnappings, demands for their substances back or their debts repaid rapidly. So that's the first signs I believe we'll start seeing.
Okay. The next question is, as I said, you're the first policeman we've interviewed, and everyone is very concerned about the health and well-being of frontline health staff. But it sounds to me like police are also really exposed. I'm just wondering what the impact has been on police health and well-being, and whether you guys are getting your PPE and whether you're protected, or are you dropping like flies like the health force?
There are a number of people isolating. I think we're no different to any other service. I think we share the same risks as someone working in a supermarket. To be honest with you, we're both frontline. We share that exposure to the general public. So there's no difference in that respect. Clearly, we have high risk areas. So if a detainee is brought in testing positive for for COVID-19, then there are robust and safe policies written with our health partners. So we share many similarities, but there's no real difference between policing, health, and other public services. I'm afraid I can't go into too much detail about the COVID-19 response plan, but because I'm simply not involved in that directly. But going back to your point about protecting those people most at risk, the vulnerable people, in our hidden communities, there's a great deal of work that I'm involved in to try and make that safer for those people, to reduce their exposure on the streets, working with hostels to develop drug tolerance policies pragmatically, enabling and helping staff to keep them safe, but also their drug users safe. And it's understanding need. Another example is what we want to try and avoid is queues at pharmacies, but then ensure their safety and safety of the staff at the pharmacies. So that's the focus of my work currently.
Okay, you've given a couple of examples around what you locally are trying to do to reduce the burden and risk to the most marginal populations. Is there anything more explicit that is likely to happen across the UK in terms of de facto decriminalization, not investing police time in, busting people for possession of small amounts of drugs? Is that something that groups are actively doing?
No, not specifically. Policing will go on largely unchanged. Currently, and not to forget, there are 43 different police forces with their own policies, and that's not to create a postcode lottery at all. Within Thames Valley Police, our diversion scheme and our processes for dealing with people in possession are largely unchanged. But for any offence, not just drugs, there is a necessity criteria. Is it necessary to arrest that person? Now, it's clear that for a drug possession case, there's an opportunity to deal with that at a later stage. For instance, why does that have to be dealt with there and then? And it doesn't. So there are other offences that need to be dealt with a lot more efficiently and effectively and quicker than others. So it's taking that pragmatic approach to what we're dealing with in front of us.
Okay. I kind of want you now to use your crystal ball and fast forward 12 months from now, when Corona has become a Netflix series and the world is starting to reflect on what longer term changes we might need to embrace. What longer term changes do you think might occur in the UK in terms of drug policy and drug treatment as a result of COVID-19?
Okay, I have a few thoughts actually. They're not helped with a crystal ball, sadly. I wish I had one of those. But clearly, I think with the lockdown, that is no doubt exposing a number of people to self-evaluate their own drug use. Enforced withdrawal is not going to be fun for anyone, whether you're using recreationally or towards more problematically. The availability of supply, particularly with those that may well have used more in the nighttime economy or the festival kind of arenas, where suddenly there is no substance, and actually they're beginning to realise actually their use is a lot more dependent than they perhaps thought or considered. So therefore now with the reduction, if you like, in the accessibility of services, so drop-ins or face-to-face have moved towards more online, and I think the more online service provision will flourish. So there are some really great charities out there. I want to name a couple. DrugFAM as a signposting and family support service, but also Breaking Free Online. There are some really great charities, but a number of large charities have and drug services have all moved to online support. So there's some great work by CGL, We Are With You, Inclusion, Cranston. There's some excellent work, and I have to really give a positive shout out to Oliver Standing of Collective Voice, because they're collating all of this best practice and really publishing some excellent resources for people to reach out to. And I think this is where stigma plays a part. So that crystal ball question, really, I think we need as a society to really break down that stigma about what addiction is, what drug use is about. So there'll be many families out there experiencing this for the first time, and actually this is a great opportunity to change that narrative about stigma and drug use, and to reach support and education about what people are using. I think longer term, for the most at risk and vulnerable, there will be a number of homeless hostels developing drug tolerance policies. I've seen some excellent work recently with Kevin Fleming. He's been around for a long time advocating some really excellent evidence-based policies that are completely lawful, and many services are adopting those now. And I think it's really important to bring the homeless sector closer together with the drug policy sector, so there's a wider collaboration, to develop policies to keep people safe. So drug tolerance policies may well be a step towards supervised injection facilities. I'm a strong advocate of supervised injection facilities, and that's not changed. There's a real need for a safe space for the most vulnerable people to use their drugs in order to be assessed and general health care and to access services. It provides a golden opportunity. That's exactly the same as a hostel with a drug tolerance policy. There's some really good examples out there. Towards different drug policy towards people who use drugs or found in possession, I think there will be a wider variety of drug diversion schemes that take people out of the criminal justice system more towards a health-based approach. There's a strong, very good developing picture from West Midlands Police, Avon and Somerset, Checkpoint in Durham, my own Thames Valley's drug diversion scheme, but they're all providing unique evidence to support people and certainly not punish them. After all, when someone's found in possession of drugs, what do you want? Is to say we share this exact view that we want people to be educated, we want people to assess about their use and to be educated, not punished.
I think that will be music to many people's ears, and I think there's an awful lot of people around the world who would hope that these lessons aren't forgotten. And the fact that there's local policy development based on local experience with local evidence base, hopefully that's going to be the thing that means we don't lose those lessons. The final thing I want to ask you was based on a question I asked you last week, because one thing that occurred to me is that lots of people who fund their drug use will be breaking into houses when there's no one in. And so I'm just curious, now that everyone's locked in, how has acquisitive crime changed? How do you burgle a house if people are in?
Yeah, another great question, really. I think it's absolutely, I mean, so shops are shut. Yeah, people are at home. The most problematic user suddenly has a real drought of income or potential income. So what are the risks? Is sex work increasing as a result? Is exploitation in other forms? So are suppliers exploiting people who their customer base to go and commit other crimes? Is aggravated burglary increasing? Is online crime or cyber crime increasing? And I'd say yes to all of those. With a different shape in the market, it's going to create other risks for a great number of people. Drugs can. I was saying this yesterday to someone in the BBC, but the drugs might go away, but the addiction doesn't, and it's still there. So it still needs to be funded. There's still a market. There's still a demand for drugs for one of the most problematic, heaviest users, and crime will adapt in order to fund that. I worry about exploitation. I worry about being people forced into areas that they've not been involved in before. I worry about a great number of people.
Okay. Jason, thank you so much for taking the time of sharing your experience and your fairly unique perspective from the policing view on just how much amazing work police can do to protect the most vulnerable in society. And I hope people watching this will hopefully find police from other countries to come and talk to us, to talk about other examples of local policy. But look, we might want to come back and catch up in a month or two and see how those dynamic drug markets have changed and see how you're going. But until that time, please stay safe. Thank you so much for taking the time to talk to us.
Thank you. And thanks for providing a brilliant service too. Global Drug Survey is excellent.
You're very kind.
Thank you. Thank you very much. Thank you.
And so the question that you chose to ask Will it be better where we're going? And though the answer I don't know for a fact, still my heart is saying, oh yeah.
Still just taking it one day at a time. Still don't know what I'm trying to find. Really I don't mind, cause I'll be fine.